Good afternoon and welcome. Thank you for joining us from around the globe for today's webinar in Bruin Biometrics Getting to Zero webinar series. My name is Dan Raffensberger, and I'll be your host for today's webinar. Today's webinar is going to be presented by Dr. Rhonda Sullivan, and it's titled, What the Risk Score Can't Tell You, Why Low-Risk Patients Still Get Pressure Injuries. This is the first in a three-part series focused on examining the limitations of the current standard of care and exploring opportunities to improve patient outcomes. Dr. Sullivan is the Vice President of Implementation and Clinical Outcomes at Bruin Biometrics. In addition to being a double doctorate prepared nurse, Dr. Sullivan has worked as a certified wound ostomy nurse for 26 years, has been certified as a legal nurse consultant for over 20 years, and is the past chair and a currently serving member of the certification board for the American Association of Legal Nurse Consultants. Dr. Sullivan is a published author, award-winning researcher, med legal expert, and approved CE provider for 17 boards of nursing. Dr. Sullivan, thank you for being with us today. I'll turn it over to you.
Thank you, Dan. During this webinar, we will use the evidence to explore limitations of the current pressure injury prevention standard of care and how the subjectivity of our current tools has prevented us from achieving meaningful reductions in preventable harm. We will also take a deep dive into why traditional risk assessments fail vulnerable patients and discuss how technology can close the gaps to make zero harm possible. Pressure injuries remain one of the most persistent sources of preventable harm in healthcare, and the impact is measurable. Nationally, there are 2.5 million pressure injuries annually, and nearly 60% are stage 3 or stage 4, meaning severe reportable events. Each injury costs $21,767 to over $175,000, as 13 to 22 unnecessary length of stay days, and increases the likelihood of 30, 60, and 90-day readmissions by 1.5 to 2 times. But pressure injuries aren't just numbers. They're preventable harm happening to someone's mother, father, sister, brother, or friend. While we track all pressure injuries, PSIO3 reflects the most severe hospital-acquired harm, stage 3, 4, and unstageable. Using AHRQ benchmarks, severe events rose from 9,897 in 2019 to 12,300 in 2022. And if the trend holds, will reach nearly 14,800 by 2025. This is a 49% increase. Remember that these numbers only reflect the most severe and costly reportable injuries. Some of the evidence suggests that this upward trend is related to patients waiting longer to seek care and presenting sicker and more complex. Other sources suggest that COVID deprioritized the focus on prevention, especially for new nurses entering the profession, and reprioritization of prevention has been delayed. Consider that all severe injuries start as minor injuries, which is an opportunity to recover the tissue or minimize the severity of injury. So why aren't the robust pressure injury prevention programs we've developed and implemented over the years resulting in meaningful reductions in harm? Well, it's because our current model relies on subjective risk assessment, subjective skin assessment, and these guide variable intervention choices. Nowhere else in healthcare do we use a tool that we know is inadequate or inaccurate to guide care. Why is pressure injury prevention different? Despite this seemingly robust standard of care with endless interventions to choose from, pressure injury rates remain unacceptably high as 26.7% in hospitals and 29% in the community. Pressure injury reductions have trailed other hospital-acquired conditions because the subjectivity of our current pressure injury prevention model results in missed risk, progression of early damage, inconsistent and ineffective prevention, persistent variability in outcomes across the institutions, and a limited return on decades of education and policy efforts. In contrast, infections like C. diff, MRSA, CAUTI, and CLABSI have achieved a 25 to 58% reduction since 2019. This is because they're driven by objective metrics, standardized evidence-based bundles with compliance tracking, and technology-enabled surveillance. This difference in objectivity is a key reason zero harm and pressure injury prevention remains elusive. So let's explore our current pressure injury prevention model, starting with risk assessment. What if the very tools we rely on to assess risk are putting our patients at risk? The International Pressure Injury Prevention and Treatment Clinical Practice Guidelines direct clinicians to conduct a risk screening on admission and periodically, followed by a risk assessment after admission and with any change in status. The risk assessment selected should be structured, population appropriate, valid, reliable, and the results interpreted based on clinical judgment. Clinicians are also instructed to consider skin status, diabetes, perfusion and oxygenation, increased body temperature, advanced age, relevant labs, and general health. How many of you are following this long, complex list of directions for risk assessment in your facility? Now consider that despite the complexity of the guidance, risk assessment is only a good practice statement in the guidelines. This means that the statement is intended to fill a gap, but lacks sufficient evidence to be recommended as a best practice. So let's assess how population appropriate, valid, and reliable today's pressure injury risk tools really are. Since the 1960s, more than 50 scales have been developed. Even today, none of these tools are considered the gold standard. An umbrella review from 2025 of 19 systematic reviews evaluated 70 tools, including machine learning models. Braden, Norton, Waterlow, Cubbon-Jackson, and modifications thereof were the most evaluated tools. This review found wide ranges in sensitivity and specificity, but overall, evidence quality was poor and clinical effectiveness remains questionable. In this review, only 2 randomized controlled trials tested the real-world impact of risk assessment, and neither showed a reduction in pressure injuries. But what about the Braden scale? Surely it performs better, right? First, let's start with the name, Braden Scale for Predicting Pressure Sore Risk. It has been decades since we referred to pressure injuries as pressure sores. If the name itself has not evolved, how relevant is the actual scale to current practice? The Braden scale was developed in the mid-1980s as a screening tool for research, and its use rapidly expanded beyond this intended use. But despite mixed results in validity and reliability, its popularity and purported ease of use have made it the most widely used risk assessment tool internationally. Practically speaking, the Braden scale has limited impact on pressure injury incidents. It's subjective, it varies by population, and it may not discriminate risk when used alone. That's why the international guidelines suggest that risk assessment always be augmented with other actions, including comprehensive skin assessment. The Braden scale also was never meant to be a guess, but in real life, nurses are asked to score risk before they even know the patient. So what happens? Scores get copied, subscales and total scales become guesses, and the opportunity to identify risk and intervene gets missed. In pressure injury litigation, the first document we scrutinize is the risk assessment. We start with the risk assessment because we know that it is rarely accurate, which provides an easy breach to causation connection. If the Braden score was copied, guessed, or inaccurately scored, that is often the first breach of duty. And once the breach is established, the defense collapses. A single autopilot Braden can turn a preventable injury into a lost case and a costly payout. But let's look at what the evidence actually says. The Braden scale is the most widely used risk assessment tool in the US and internationally. So it's a logical foundation for evaluating the effectiveness of risk assessment today. In the largest review of the Braden scale, which included 60 studies and nearly 50,000 patients. The overall sensitivity and specificity were 78% and 72% respectively, showing only moderate predictive validity. Performance also varies depending on the cut score, with an optimal threshold of 18. And accuracy is highest in hospitalized patients under 60 and in Caucasian populations. Its accuracy drops in older adults and in critical care settings, excuse me, where oxygenation, perfusion, and other key risk factors aren't captured. That's why hybrid approaches like Braden Plus have emerged as attempts to address these gaps. Modified versions of the Braden scale perform much better, reporting up to 97% sensitivity and 89% specificity, largely because they were updated to address known limitations in the original tool. And those limitations are significant. This table shows 18 risk factors that repeatedly appear in large, well-designed pressure injury risk studies. The Braden scale measures 2 of these 18 statistically significant risk factors. In other words, it does not assess for most of the strongest predictors of pressure injury risk, such as prior pressure injury, oxygenation and perfusion status, sedation, vasoactive agents, mechanical ventilation, incontinence, edema, and differences in skin tone. These gaps are further supported by a large meta-analysis across more than 70,000 hospitalized patients. The authors reported an overall pressure injury prevalence of 8.2% and identified 8 major drivers, which include age, immobility, incontinence, nutrition, diabetes, ICU exposure, length of stay, and time to surgery. 6 of these 8 major drivers are not measured by Braden. The international guidelines stress that risk assessment should be population appropriate. So let's look at the appropriateness and effectiveness of risk assessments in some high-risk populations, starting with the emergency department. According to the evidence, there are no validated ED-specific risk assessment tools, and Braden is the most used risk assessment tool in the emergency department. ED-specific risks include older age, multiple comorbidities, high CRP, cervical spine immobilization, ambulance arrival, and hypotension. Yet none of these factors are measured by the Braden scale, highlighting a major gap in ED risk assessment. Given that ECQM requires reporting of stage 2 or greater HAPIs and will be mandatory in 2028, the need to adequately identify risk and early pressure injuries on admission couldn't be greater. Intensive care units commonly have the highest incidence of pressure injuries, as high as 34.4%. Patients with an ICU stay also experience pressure injuries that are often more severe and more costly. Despite wide variation in reliability and predictive accuracy, the Braden scale is the most widely used pressure injury risk assessment tool in the ICU. But the evidence shows it often falls short. A 2024 systematic review of the psychometric properties of Braden in the ICU across 34 studies from 11 countries suggested that it does a poor job of predicting who will get a pressure injury. And this is because it omits ICU-specific risks like oxygenation, perfusion, and medical devices. And it also requires a lower cut score, 12 to 14 as opposed to 18. The use of Braden in the ICU, despite its known limitations, leads to inconsistent decision-making, including overclassification of risk and misdirection of prevention resources. The operating room is another high-risk setting for development of pressure injuries, with a meta-analysis of 24 studies across 6,721 patients reporting a rate of 12.3%. Independent risk for pressure injuries in the perioperative setting include diabetes, hypertension, hyperlipidemia, abnormal BMI, and advanced age. Again, none of which are assessed by Braden. However, Braden remains the most commonly used risk assessment in the perioperative setting, despite the availability of more appropriate tools. Now let's talk about skin tone as a risk. Skin tone diversity can increase pressure injury risk because the visual cues clinicians are taught to look for often appear differently or are missed in patients with darker skin tones. Evidence shows that these patients face a 60% greater risk of pressure injuries, are more likely to experience multiple or more severe injuries, and are 4 times more likely to die from pressure injury related causes. One driver is under detection in early stages, since skin manifestations may not present in the classic way. The result is longer hospital stays, higher costs, and worse outcomes. The reality is that there are no bedside risk assessment tools that currently include skin tone as a risk category to date, but there should be. While pressure injuries can develop for 3 to 10 days under the skin, our current tools focus on external risk factors and visible skin changes. The elephant in the room is that traditional risk assessment misses what matters in pressure injury prevention. A biology-based approach, like subepidermal moisture assessment, closes that gap by detecting early tissue injury as opposed to general risk, allowing us to intervene sooner and prevent harm. All pressure injuries start with a triggering event, whereby pressure and shear disrupts blood flow, deforms the tissues, and damages cells. The body responds with inflammation, and as the cells become stressed and begin to die, fluid leaks into the dermis and subdermis. This fluid is subepidermal moisture, or SEM, also known as persistent focal edema. SEM is one of the earliest biologic signs of tissue stress and evolving deep tissue pressure injury, developing 3 to 10 days before visible skin damage. SEM assessment allows clinicians to detect what the eye can't see, intervene sooner, and stop the cascade before a visible pressure injury occurs. To keep patients, you, and your organization safe from legal and regulatory scrutiny, always do your due diligence. Ask for evidence and FDA clearance for any medical device. Confirm how the device is authorized by the FDA to be used. Use of a product or a medical device beyond its intended scope and approved use puts everyone at risk. The Provisio SIM scanner is the only SIM assessment technology and the only non-invasive skin and tissue assessment tool FDA cleared for pressure injury management. The SIM scanner uses an objective, evidence-based, and validated method to assess subepidermal moisture, provides a statistically derived, easy-to-interpret cut score to guide intervention, and is the only technology with an ICD-10 PCS code and a direct coding pathway for present on admission. While the Provisio SIM scanner is a newer breakthrough technology, the science behind it is extensive. The technology is backed by more than 200 pieces of evidence and 90 plus peer-reviewed publications, including systematic reviews, consensus guidelines, and health economic studies. The evidence suggests that the Provisio SIM scanner can detect non-visible injury 3 to 10 days, a median of 5 days before skin changes appear, with high sensitivity and specificity, and is statistically better than visual assessment, risk assessment, and clinical judgment. In real-world use, across 34 facilities and more than 2,400 patients, SIM integration resulted in a 90.5% reduction in HAPIs overall, including 100% reduction in ICUs. These are outcomes that support equitable detection across all skin tones and make zero harm possible. SIM assessment overcomes risk assessment limitations by measuring the biologic response to pressure and shear. As tissue damage develops, biocapacitance increases. The Provisio SIM scanner assesses for and quantifies SIM levels across 6 areas on the sacrum and 4 areas on each heel, then calculates a SIM delta. The SIM delta is the difference between healthy tissue and stressed tissue. A SIM delta of 0.6 or greater indicates pressure damage. So you're probably wondering how SIM fits into everyday practice. Well, it is as easy as 1, 2, 3. During your comprehensive skin assessment, you scan the sacrum and the heels, which takes around 2 minutes when incorporated into usual care. The scanner will provide a SIM delta for each site. Then you treat each delta individually. SIM assessment helps organizations shift to biology-based, individualized, patient-centered prevention because the SIM delta reflects how tissue is responding to pressure and shear at a specific anatomical location. A green delta below zero point 0.6 means your current prevention is working, continue your interventions. An orange delta of zero point 0.6 or greater means early tissue injury is developing, even if the skin looks normal. Immediate action is needed to reverse the damage. Every elevated delta is an opportunity to reassess your care by asking 3 questions. Are the interventions in place per protocol, and are they being executed correctly? If no, address the identified care gap. Then assess whether the interventions are working. If not, escalate the care. If your interventions are effective, the orange SIM delta will trend down and the goal is always green. This case shows how SIM deltas guide anatomy-specific prevention and confirm whether interventions are working. For the sacrum, the delta starts elevated at 0 0.6, rises to 1.2, and peaks at 2.8, indicating significant tissue stress consistent with a non-visible deep tissue pressure injury. The nurse implemented side-to-side positioning, increased offloading, and added a foam dressing, and the sacral delta rapidly improved to 0 0.8, then normalized to 0 0.5 and 0 0.3, supporting the notion that deep tissue pressure injuries can recover if treated early. For the left heel, the delta was high on admission at 1.2, suggesting a non-visible stage 1 pressure injury present on admission. Pillow offloading was initiated and maintained, and the delta steadily decreased to 0 0.9 and 0 0.7, then normalized to 0 0.3 and 0 0.2, confirming tissue recovery. For the right heel, deltas remain normal at 0 0.5 or less, indicating no pressure damage. Routine prevention was initiated and maintained, and the delta stayed normal throughout the hospital stay. As we close, it is important to acknowledge something we all know in practice. Risk assessment is expected in pressure injury prevention, but it's not enough. Risk assessment tools are subjective and often inconsistent, inaccurate, and incomplete, which may lead to missed chances to prevent harm. Even when completed correctly, they omit known pressure injury risk and merely indicate who is at risk, not where the tissue damage is developing. SIM assessment fills that gap. It provides an objective, physiology-based insight into tissue health and detects injury before it's visible, creating a measurable and actionable path to zero harm. And that's why the Provisio SIM scanner is an essential component of effective pressure injury prevention. It strengthens assessment and clinical judgment by guiding early and more responsive interventions and improving documentation and quality reporting. The best practice model is simple. Use Braden to understand why a patient is vulnerable and SIM to know where and when tissue injury is starting. Together, they create a stronger, outcome-driven prevention system that can move your organization closer to zero preventable pressure injuries. Thank you for listening.
Thank you, Dr. Sullivan, for presenting on such an important topic. And thank you for those in attendance for joining today's webinar on pressure injury risk assessment. If you'd like to learn more about how we, Bruin Biometrics, can help organizations move towards zero harm, please feel free to reach out to us. The contact information for Dr. Sullivan, Karen Schock, and myself is on the screen. Now let's take a moment and open it up for some questions. don't know that we have any questions at this time, but if folks do have questions, please take advantage of the opportunity, the chat feature, in order to maybe ask any questions that you may have on this important topic about risk assessment tools.
So there are some questions in the Q&A. One is there research for the use in long-term care? Absolutely. A lot of the early studies on risk assessment were done in long-term care. Some of the studies I presented in this presentation were also done across multiple, the care continuum, so they represent long-term care as well.
Rhonda, we've had a few more questions roll in through the chat feature as well.
Okay.
The first one was, would you be willing to share your presentation? We do post a video of the presentation and the information up on our website. So more than likely, you're going to receive an email from us with a link to where this information will be available, probably in about 24 hours after the webinar. Another one, and I think you've addressed this one, Rhonda, was, is there research for the use of this area in the long-term care environment? I think we've got the answer there. Another question came in, could this be used for diabetic foot ulcers?
So it is not indicated by the FDA for diabetic foot ulcers, but I believe some of the early studies on subepidermal moisture were done on diabetic foot ulcers. But today, no, we don't have FDA clearance to use it for diabetic foot ulcers. But it sounds like a study that you might be willing to do.
Rhonda, another question came in. The question was about, how often do you recommend scanning?
So we recommend scanning always, always, always on admission because of its ability to support present on admission. If you have an elevated delta on admission, we recommend scanning at least 2 additional days because that's going to help you document the presence of a developing deep tissue injury. And I'm speaking specifically in reference to ECQM. And then in most acute care settings, they scan daily. And then in long-term care or post-acute, it's generally twice a week.
Perfect.
Another situation is when they leave the unit and come back, or if they leave the facility and come back, we recommend scanning too, so that you have some level of assessment of what happened while that person was outside of your facility or off your unit.
Rhonda, another question that came in, is the use of SEM safe on frail, thin, elderly skin? And if so, are there any studies to support this?
Yeah, so as I alluded to, a lot of the early studies were done in the long-term care setting where the majority of the patients are elderly and frail. But I can tell you in practice, even today, we spend a lot of time in the hospitals, in the actual units, working with the clinicians, and there are a lot of elderly, frail people. But I think that if you understand the science behind SIM, it absolutely works for elderly, frail. It also works across skin tones because all it's doing is looking for that elevated level of SIM into the dermis. Everybody has a dermis. Even if it's thinner in older people, they still have a dermis, and that's where SIM is finding that subepidermal moisture.
Great. Dr. Sullivan, we have another one. Any recommendations for patients on vasoactive medications in vents?
So I will say it's used quite often in that patient population, and it's because a lot of our initial implementations are in the ICU, and then we expand beyond. So yes, but the vasoactives as well. So if you're asking about skin changes related to vasopressors or vasoactive drugs, it will differentiate that from pressure. And the way that it does it, so subepidermal moisture is a biomarker of this tissue deformation-induced injury. Vasoactive drugs are not deformation-induced injuries. They're because of that altered perfusion from the the drugs. And so it will differentiate that from vasoactive injuries.
Okay. Dr. Sullivan, we have a few more coming in. Do you have a suggested protocol for interventions? For example, what to escalate to if a SEM score does not go down?
So we have a library of protocols. But I think one of the things that we have learned over time is that because we do bundled care, we find more often that it's not always a new intervention that you're adding. It's applying the one that you were supposed to add in the first place. And so that's why when you heard me reference the 3 questions, the first thing we do before adding anything else is assess what we're already doing. So have I applied everything I was supposed to apply based on our protocol? Is it executed appropriately? And that really speaks to, is that sacral dressing really on the sacrum? Or is it too high or too low? Or did the person kick the boot off? Or is the boot on, but the heel's not in the cradle? And then are the interventions working? Because, that reassessment piece is key, because a lot of times it's just we got in a rush. We meant to do it, we didn't, or we did it, but we didn't do it correctly. But I will tell you, a lot of the escalation protocols include things like sacral foams, support surfaces, chair cushions, things like that, that may not necessarily be in your basic bundle, and we escalate to those.
Right. And I know there's those protocols that you mentioned, Rhonda. Folks can feel free to reach out to us. We'd be more than willing to talk to you about those protocols and share protocols with you. Rhonda, one more question came in. Is it recommended to use just in the ICU setting or all patients in a medical center?
I would say, so we start with the ICU typically because when we work with the facility, we always say to give us your highest prevalence unit, and that just happens to be the ICU. But from a present on admission perspective, we recommend scanning every unit, every admission, so that you can get in that medical record if they have a present on admission pressure injury that you can't see. But outside of that POA framework, most facilities scan in the ICU and then expand to higher prevalence, higher incidence units after the ICUs. But yes, we do recommend scanning anywhere high-risk patients or at-risk patients are.
Perfect. For Rhonda in the audience, I do believe at this point we've addressed many of the questions that have come in and all of the questions that have come in. We're happy to answer any additional questions that you guys may have. Before we conclude today's webinar, I do want to highlight kind of the second part in our 3-part series, the webinar that's coming up on February 18th at 1 o'clock Eastern Time. We'll be presenting on a topic that I think is very important. It's what you can't see can harm patients. The webinar is focused on the blind spots of the visual skin assessment and how missed non-visible tissue damage can lead to preventable harm. We'll also show how earlier objective insight enables more timely intervention and better outcomes. Registration is available now by the QR code on your screen. Thank you again for all of the time that everybody spent with us this afternoon. We will be following up with an email with a link to the video so that you can share it with others within your organization. Thank you. Take care. Have a great day.
Thank you.